السلام عليكم ورحمة الله. الأول طبعا يعني أنا ببقى فرحان جدا لما برجع بلدي. أنا طبعا بقالي في عمان 25 سنة، ريكورد ربع قرن بيوبيل فضي الحمد لله. فلكن لما برجع مصر طبعا أم الدنيا وحبيبتنا وأمنا والوالدة العزيزة موجودة فيها لسه، ربنا يخليها ويحفظها يديها الصحة والعمر. واشكر طبعا اللجنه المنظمه وعلى راسهم استاذتنا الفاضله الدكتوره امال البشلاوي، وبحيي كل اللي موجودين كلهم تقريبا اعرفهم. واعتقد الدكتور شبل قاعد امانج الحاضرين. الدكتور شبل كان من الناس اللي بقتني استاذ هنا في مصر، فله كل التحيه والتقدير. كان في اللجنه، هو مش فاكرني لكن انا فاكر اللي فالحمد لله رب العالمين. The topic today will be about a new look into hemolysis in sickle cell disease, and we will discuss whether it is the main player. لأن احنا طول عمرنا we know that sickle cell disease is due to vaso-occlusion. So my task during these 20 minutes is just to try to challenge this. This is a beautiful place I work in, which is Sultan Qaboos University, with the tower. Allah yarhamu ba Sultan Qaboos. So sickle cell disease, from long time we know this slide, that it is due to a point mutation in the position 6 of the beta globin chain, and this minor mutation will change glutamic acid into valine in the position 6, and this will result in a lot of change in properties of the hemoglobin. So instead of being it will be hydroscopic, and it will absorb more water, and this result in sickling and polymerization. This is what we have known for years. But this concept, which is valid for many years since I was a medical student, is now challenged. The main pathophysiologic mechanism of sickle cell disease is vaso-occlusion. Still, vaso-occlusion is there, but whether it is the main player or not, we are going to discuss that. There are many recent evidences from research studies and clinical trials that the main drive behind the pathophysiologic mechanism, clinical manifestation, complications, and organ damage, and even mortality in sickle cell disease is chronic hemolysis, which result, as I will show you later, into a chronic inflammatory state and activation of coagulation. And this actually activation of coagulation will result into vaso-occlusion. So a lot of recent evidence for that. And the lower the steady state hemoglobin, the worse is sickle cell disease. We listen to many lectures in the morning, and the lower the steady state hemoglobin in thalassemia intermedia, the worse is the disease. So there is a critical level, and I'm not sure what exact level is, because when we see in the lecture, the differences is like 0.5 gram, 0.9 gram makes a lot of difference in the prognosis of sickle cell disease. However, the higher hemoglobin is the better. So sickle cell disease is a monogenic with pleomorphic manifestation. We have hemolytic manifestations, the anemia, the CNS, neurocognitive damage, pulmonary hypertension, cardiovascular nephropathy, priapism, leg ulcers, relative systemic hypertension. All of these are related mainly to hemolysis, and this has been known for years, not new. And the other part of the spectrum is the vaso-occlusion, where vaso-occlusion results into acute painful crisis, acute chest syndrome, diastolic cardiomyopathy, retinopathy, hepatopathy, splenic infarct, mesenteric ischemia, avascular necrosis, and fat emboli syndrome, which is part of acute chest syndrome. So these are the vaso-occlusive manifestations. However, there is an evidence that byproducts of hemolysis will cause chronic inflammation and activation of coagulation. So if you look into this very important slide, the hemoglobin S polymerization, the hemolysis and the anemia, actually it is in the center. It leads to oxidative stress, free hemoglobin and heme, reduced nitric oxide bioavailability and red blood cell membrane fragments. This will result in coagulation, endothelial activation, and inflammation. And if we look into that, this all result into vaso-occlusion. Anyhow, it's like a visual circle. So this all will result in hemoglobin S polymerization and hemolysis and sickling. And on the other, all these together will lead to end organ damage at the end. So chronic hemolytic anemia, vaso-occlusion, hypoxia leads to vascular injury and the progressive end organ damage. If we look into the evidence from the clinical trials, we will find that there is a very good association between the level of hemoglobin or anemia and the clinical complications of sickle cell disease. And the focus nowadays is on 3 organs, which are the lung, so there will be our cardiovascular, elevated pulmonary artery systolic blood pressure, albuminuria, so the kidney, and then the brain, abnormal TCD, and stroke in sickle cell disease or silent cerebral infarct, and again death. So if you look into this mild to moderate reduction in hemoglobin may be of clinical significance. The difference between, and you can see that the differences in hemoglobin between the groups which show bad complications are only 0.9, 0.6, or 0.4 even, 0.5 grams only. And not only from this single study, but a meta-analysis of 41, which is the best level of evidence, studies demonstrated that mean hemoglobin was significantly lower in the children and adults with clinical complications of sickle cell disease. And again, we are focusing on the cardiovascular system and the lung, pulmonary hypertension, kidney, albuminuria, and the brain. So what are the organ complications of sickle cell disease? We know that they start in the childhood. So if you look at the brain, neurocognitive impairment, retinopathy, left ventricular hypertrophy, renal impairment, and priapism, they can all start in childhood, and also overt or silent clinical cerebral infarct, hearing impairment, acute chest syndrome, splenic dysfunction, and AVN. On the left side, they are mainly the hemolytic manifestations. On the right side, they are the vaso-occlusive manifestations. This will continue through adulthood, and what happened actually, I will not go through them again, but this will result in end organ damage of all these organs. So when I went to Oman, Oman is full of sickle cell disease. We have around now maybe 10,000 cases. Unfortunately, the premarital screening program is not compulsory. That's why still we got a lot of sickle cell disease. So when I went to Oman, I found that the adults, 25, 26, they are walking with oxygen concentrators on their back. Many of them pulmonary hypertension. Many of them, at this time, we don't, the use of hydroxyurea was not there. And we will come later to how the hydroxyurea improved these patients a lot by targeting this hemolytic part. So, sickle cell disease, in conclusion, has been transformed from an acute episodic condition of vaso-occlusive crisis, which you all know, to a chronic progressive inflammatory disease of adults. And as the children lives into adulthood, individuals with sickle cell disease are facing increasing burden of end organ damage, which leads to poor quality of life, high morbidity, and early mortality. Hemoglobin S polymerization is a central event of sickle cell disease, which leads to vascular injury. Anemia and hemolysis play an important role in this polymerization. And anemia and hemolysis also play an important role in development of end organ damage. And the progressive organ-specific vasculopathy often precedes the clinically evident organ dysfunction. So we can see, for example, the albuminuria preceding the changes of renal failure. End organ damage start early in pediatrics. However, we are lucky as pediatricians because many of these complications are really the adult physicians are the one who are facing this complication. However, once end organ damage is present, it is very very difficult to reverse. I still remember one of my patients who developed pulmonary hypertension, which is irreversible, and it was actually fatal. He died out of that long time back. So nothing to help him. He was working with the oxygen and nothing to be done more than that. So the organs, again, what are the main organs? CNS, lung, and kidney. This is actually a very interesting cave in Oman, شبه جعيتا بتاع لبنان. مغارة جعيتا، بس الفرق بينه وبين جعيتا انه بينطوا فيه بالباراشوت. انا طبعا عمري ما نطيت، انه لا بنبص من بره كده، لكن مستحيل تنط. بينطوا فيه، اللي بينطوا فيه 99% منهم اجانب. لا العرب بيخافوا. فانيهاو فيري انترستنج. اسمه لانه طبعا اي حاجه بتبقى عميقه وفيها ميه وكده، فكانوا مسمينه في عمان بتوع الناس بتوع المنطقه دي مجلس الجن او كهف الجن. الجن قاعدين فيه يعني. مجلس الجن، جيني كيف. لا في الشرقيه، في المنطقه الشرقيه. لا في الشرق، في الحته جنب حته اسمها صور. فهي عارفه بقى عمان صلاله وكله. يبقى قلنا ان الهيموليسيس increase the risk of serious complications in sickle cell disease. الكلينيكال ايفيدنس، الهاي تي سي دي فيلوسيتي، ستروك، سايلنت انفاركت. على الهارت pulmonary hypertension والترايكاسبيد ريجورج فيلوسيتي بتبقى عاليه. كدني ديزيز، بارابيزم اند ليج ulcers. So anemia and hemolysis contribute actually to increase the risk of stroke and the neurocognitive impairment in sickle cell disease. How? The anemia reduces the oxygen delivery to the brain, decrease the cerebrovascular reserve, and severity of anemia correlates with abnormal TCD. And this was very interesting finding. We did a large study on TCD on Omani population. We screened around maybe 600 children, and there was a good correlation between the level of hemoglobin, the lower level of hemoglobin, and the higher TCD's values. And also other literature, a lot of literature about that trials are still going on. Hemolysis also releases the cell-free hemoglobin, which scavenges nitric oxide and facilitate the organ damage and the endothelial damage. And this all result in what we call cerebral vasculopathy with increased risk of stroke, silent infarct, and neurocognitive problems. And this has been shown not only in that, but also in other clinical trials. So the lower the hemoglobin levels, the higher the risk of the stroke. The lower the hemoglobin level, the higher the risk of silent cerebrovascular infarct. And this was another evidence of hemolysis, not only the hemoglobin level, but also the reticulocytic count. We know that the higher reticulocytic count, and by the way, we in Oman, they don't give the percent, they give the absolute value. So the retic's absolute value is from 20 to 150. So 300 اللي هي أعلى واحدة فوق هنا. 300 دي is almost double the normal reticulocytic count. And it is the higher the reticulocytic count is associated with higher mortality by very clear on the Kaplan-Meier curve of survival. So hemolysis severity is associated with increased risk of stroke in children with sickle cell disease. And sorry, this is Kaplan-Meier curve not for survival, for events. So here, the development of stroke is much higher in patients with higher reticulocytic count. So another evidence that hemolysis can cause CNS damage. The second organ, anemia and hemolysis contribute to the development of pulmonary hypertension in sickle cell disease. Again, almost similar mechanism in that the nitric oxide depletion will result in systemic and pulmonary hypertension due to vasoconstriction. The anemia will lead to increased cardiac output and play a role in pulmonary hypertension. And once it has happened, there will be increase in the cardiac flow and contribute to elevated pulmonary pressure. So this has been also proven in clinical trials. And we can see that they got what we call a surrogate marker. The surrogate marker is the tricuspid regurg velocity. So when the tricuspid regurg velocity is higher, this means that there is indirect evidence of pulmonary hypertension. So they found good correlation between low level of hemoglobin and the tricuspid regurg velocity. It is more here than 2.5 millimeter per second. And also for the reticulocytic count. So the higher the reticulocytic count and the lower the hemoglobin, the higher the tricuspid regurg velocity. Again, a surrogate marker for hemolysis. This has been proven not only in children, but also in adults. As you can see, that the lower hemoglobin level, but here the other marker of hemolysis was not the reticulocytic count, but here they used the indirect bilirubin. So those patients with higher indirect bilirubin, they have higher tricuspid regurg value, and with lower hemoglobin level, the adult patient, they have also higher tricuspid regurg value, indicating early pulmonary hypertension. So again, the lung is affected mainly by hemolysis. Anemia and hemolysis also contribute to kidney disease and sickle cell disease. So anemia leads to compensatory increase in cardiac output, resulting in renal hyperperfusion and glomerular vascular injury. And also hemolysis will release the heme, which facilitate oxidative damage and defects in the renal vasoregulation. All of them will result in chronic kidney disease, renal vasculopathy, and progressive kidney disease. And we have seen in adult many patients with actually renal failure at the age of 40 or 45. So also there is many clinical trials showing, literature showing that the lower hemoglobin level, the higher LDH as another marker of hemolysis, the higher bilirubin in the children with sickle cell disease are associated with microalbuminuria, which is here a marker of glomerular damage. This happens very much earlier than elevated serum creatinine. So the microalbuminuria is very important, particularly in those who are treating the adults. They checked in our clinic, in adult clinic, they check the microalbuminuria once yearly for adult patients with sickle cell disease, particularly those with lower hemoglobin levels. Again, this has been not only proven in children, but also in adults. Again, the same markers, the lower hemoglobin levels and the higher bilirubin. So all of this will be associated with a broad range of quality of life impacts, and the sickle cell disease patients, they have significantly reduced health-related quality of life in many domains that begins in childhood and progressive with age, including all of them, which we can see on the left-hand side of the slide. However, what I want to say here is there is a paper now, but not published yet. They are relating to poorer quality of life in those patients with lower hemoglobin levels, but it didn't finish yet. It didn't, not published. So all of this, what is the most feared complication of sickle cell disease, of course, is the mortality. So what are the causes of mortality and the predictors of mortality? In this very nice oral abstract presented in ASH in 2018, they found that the hemoglobin level in those patients on the left-hand side with hydroxyurea or with or without hydroxyurea is the most important. مش مشكلة. فهو باين يعني الهيموجلوبين ليفل على اخر حاجه هناك. The hemoglobin level, the lower the hemoglobin level, it's a very good predictor of death. So even in patients with hydroxyurea, and this is a very important clinical observation for patients with sickle cell disease on hydroxyurea, hydroxyurea at even 10 milligram, we call them super responders per kilo per day, they respond very well for the vaso-occlusion. However, the hemoglobin will not increase. You need a minimum of 25 milligram per kilo per day of hydroxyurea to raise the hemoglobin level. And sometimes we reach up to 30 or 35 milligram. But if you are able to get an increase of 2 grams from the steady state hemoglobin of the base hemoglobin level in sickle cell disease patient. If you raise them by 2 grams, this is a very great achievement, and it will reflect positively on so many aspects of sickle cell disease, and it will delay the end organ damage. So if I'm treating my patient with a hemoglobin of 6.5, 6.7, this is a steady state hemoglobin, I need to give him hydroxyurea in higher, much higher dose to reach 8.5 or 9. And this will be real great achievement in patients with sickle cell disease. So if you are able to increase the hemoglobin level, you will be, they will have much better outcome. If you see that many associations between the clinical manifestation and the survival in sickle cell or predictor of death, you will find many of them are those due to hemolysis, not due to, so the pulmonary hypertension, the leg ulcers, the CNS events, all of them are associated with poor survival, and only the one due to VOC, which is the vaso-occlusive crisis, pain crisis, is also associated. One parameter, but all the other parameters are hemolytic parameters. So, hemolysis severity is associated with increased risk of this in sickle cell disease patient, and in the same previous trial, you can see that the absolute reticulocytic count, the higher absolute reticulocytic count, did not result only in stroke or high transcranial Doppler value, but also in higher death, higher mortality. And again, in adult with sickle cell disease, they used the lactate dehydrogenase as the marker of hemolysis. And if you have low lactate dehydrogenase, again, the survival will be much better. So, what are the conclusions, the take-home messages out of that? There are big take-home messages. Advances in understanding pathophysiology of sickle cell disease has changed its paradigm. Hemoglobin S polymerization and red blood cell sickling are the root causes of pathophysiology in sickle cell disease, leading to anemia, hemolysis, and vaso-occlusion. Studies have found that chronic hemolysis, anemia, and hemolysis are associated with progressive sickle cell complications, stroke, silent cerebral infarct, kidney damage, pulmonary hypertension, and mortality, decreased life expectancy. Studies have demonstrated that anemia and hemolysis are associated with end organ damage, which is the major cause of death in people with sickle cell disease. So, in summary, hemolysis is the main player in sickle cell disease. In my humble opinion, it is yes. And please, all those who are treating sickle cell disease, try as much as you can to increase the hemoglobin level by the hydroxyurea or the new brilliant drug, which is still very expensive, called voxelotor. These two drugs are the only known drugs that increase the hemoglobin. But as I told you, the hemoglobin level, that the dose should be higher. The other issue, if you cannot raise the hemoglobin with hydroxyurea, then بنحولهم زي الثلاسيميا، بنحطهم على simple transfusion من 6 ل 9، يجوا ياخدوا كل شهر من 6 ل 9. And if you remember Eliud Vishinsky, Professor Eliud Vishinsky, brilliant paper from the sickle cell study group، كان حاططهم على simple transfusion لأنه many all of these patients كانوا عندهم very low hemoglobin, and before the use of hydroxyurea, the simple transfusion therapy was the main therapy in patients with sickle cell disease. فاكشولي من غير ما كانوا يعرفوا انه في hemolysis, they started the simple transfusion، وفائدته الاساسيه ان هو بيعلي الستيدي ستيت hemoglobin في sickle cell disease. With that, I would like to thank you all for listening.